Hello and welcome to our new topic. Today we will explore drugs used to control Parkinson's disease. Parkinson's disease results from degeneration of dopaminergic neurons in the substantia nigra pars compacta. This leads to dopamine deficiency in the striatum, producing an imbalance between dopaminergic inhibition and cholinergic excitation. The pharmacologic goal is not cure, but symptomatic control by restoring this balance. So, let's start. The learning objectives are shown. Please take a look. This slide reviews the major components of the basal ganglia, including the striatum, globus pallidus, subthalamic nucleus, and substantia nigra in coronal section of human brain. These structures regulate voluntary movement by modulating motor cortex output rather than directly initiating movement. There are multiple dopaminergic circuits or pathways in the brain. The most relevant dopaminergic pathway for Parkinson's disease is nigrostriatal system. Other pathways explain the side effects of the drugs used in this disorder. The direct pathway facilitates movement, while the indirect pathway inhibits movement. Dopamine stimulates the direct pathway and suppresses the indirect pathway. Loss of dopamine therefore leads to excessive inhibition of movement, producing bradykinesia and rigidity. Corticothalamic excitatory inputs enter the striatum, where they are transformed into two inhibitory projections called the direct and indirect pathways. In direct pathway, the striatal neurons form inhibitory synapses to the globus pallidus internus, substantia nigra pars reticulata complex, that connects to the cortex via the motor thalamus, and inhibits it. While, in indirect pathway, the striatal neurons does a similar inhibitory function but through inhibiting globus pallidus externus. The opposite effects of these two pathways control the movements. Dopamine level dynamically modulates this circuit. It activates the direct pathway and inhibits the indirect pathway through the D1 and D2 receptors in the striatum, respectively. This slide highlights the imbalance between dopamine and acetylcholine in the striatum. Dopamine normally counterbalances acetylcholine. Therefore, dopamine deficiency leads to relative cholinergic overactivity, which contributes particularly to tremor. The therapeutic strategy in Parkinson's disease follows two major principles: either increase dopaminergic transmission or reduce cholinergic activity. Most drugs act by enhancing dopamine availability or action, while anticholinergics reduce opposing cholinergic tone. Anti-Parkinsonism drugs are classified based on their mechanism: dopamine precursor therapy, dopamine agonists, MAO-B inhibitors, COMT inhibitors, central anticholinergics, and drugs with mixed mechanisms such as amantadine. The ABCDE mnemonic is a useful way to remember major drug classes: amantadine, bromocriptine and other dopamine agonists, cholinelytics, dopamine precursor L-DOPA, and enzyme inhibitors. This helps organize pharmacology logically. This slide shows how various drugs may act synergistically to control the motor symptoms in Parkinson's disease, peripherally as well as centrally. Take a look and make a mind map. Dopamine itself cannot cross the blood-brain barrier, so levodopa, its precursor, is used. Levodopa is transported into the brain and converted to dopamine, making it the most effective drug for symptomatic control. Levodopa is combined with carbidopa to inhibit peripheral decarboxylation. This increases the fraction of levodopa reaching the brain and reduces peripheral adverse effects such as nausea and cardiovascular toxicity. Levodopa improves bradykinesia and rigidity most effectively, while tremor is variably responsive. It remains the gold standard for symptomatic treatment, particularly in older patients. Carbidopa is combined with levodopa so that its peripheral decarboxylation is minimized as explained. Adverse effects include nausea, vomiting, hypotension, and dyskinesias. Long-term use leads to motor complications such as wearing off and on-off phenomena. Wearing off refers to predictable loss of benefit before the next dose, whereas on-off phenomenon is unpredictable switching between mobility and immobility. These complications reflect disease progression in pulsatile dopamine stimulation. Wearing off occurs predictably as dopamine levels fall. On-off phenomenon is unpredictable and reflects altered dopamine receptor responsiveness. These complications dictate the need for adjunct therapy, such as entacapone shown here. Dopamine agonists directly stimulate dopamine receptors and have longer half-lives than levodopa. These drugs can cause nausea, hypotension, hallucinations, impulse control disorders, and excessive daytime sleepiness. They are less well tolerated in elderly patients. They are particularly useful in younger patients to delay levodopa initiation and reduce long-term motor complications. Anticholinergics reduce tremor by decreasing relative cholinergic dominance in the striatum. However, they cause cognitive impairment and autonomic side effects. Their role today is limited to young patients with tremor-predominant disease. The autonomic side effects include dry mouth, urinary retention, and are best avoided in elderly patients. Their role today is limited to treat drug-induced Parkinsonism or in young patients with tremor-predominant disease. This diagram shows that dopamine, a catecholamine neurotransmitter, undergoes phase 1 metabolism through monoamine oxidase. It also undergoes methylation as phase 2 metabolism through catechol-O-methyltransferase. Inhibiting either enzyme would increase the half-life of dopamine. MAO-B inhibitors such as selegiline and rasagiline inhibit dopamine breakdown in the brain, prolonging its action. They are useful in early disease and as add-on therapy to reduce wearing off. COMT inhibitors such as entacapone prevent peripheral breakdown of levodopa, prolonging its duration of action. They are always used as adjuncts and help smooth motor fluctuations. This slide shows potentiation of cardiovascular effects of tyramine, seen after consuming cheese concomitantly with a monoamine oxidase inhibitor. Hence, it is called cheese reaction. Tyramine, present in cheese, chicken liver and certain other foods, increases release of catecholamines by neurons and leads to symptoms of sympathetic stimulation. It is metabolized by monoamine oxidase, hence an inhibitor will lead to these side effects. Amantadine has multiple mechanisms including increased dopamine release and NMDA receptor blockade. It is particularly useful for levodopa-induced dyskinesias, making it valuable in advanced disease. This slide summarizes a modern approach to treatment. Therapy is individualized based on age, cognitive status, symptom severity, and functional impairment rather than a one-size-fits-all strategy. Younger patients are often started on dopamine agonists or MAO-B inhibitors, while older patients or those with cognitive impairment benefit more from levodopa due to better tolerability. As disease progresses, adjunctive therapies are added to manage wearing off and dyskinesias. Dose adjustment and combination therapy are key strategies. In advanced disease with disabling motor fluctuations, device-based therapies such as deep brain stimulation or continuous dopaminergic infusion may be considered. Parkinson's disease also includes non-motor symptoms such as depression, psychosis, sleep disturbances, and autonomic dysfunction. These often require separate pharmacologic management. Key take-home messages. Levodopa remains the most effective drug, but timing and patient selection are critical. Treatment must be individualized, regularly reassessed, and adjusted as the disease progresses. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!